think we are good to go. So my name is Kelly Farrell. I'm an occupational therapist at Cincinnati Children's.
And I'm Kim. I'm a physical therapist at Cincinnati Children's.
And we are here today to talk about cerebral palsy, and we're super excited. CP or March is CP Awareness Month, and it's a great way to end the month, kind of presenting and giving you guys the information. So we encourage breaks and questions along the way. There's a lot of information, so we really won't have time. So feel free to eat, take a break, take a bathroom break whenever you need it. So the learning objectives for today are going to be, after this lecture, you guys are going to be able to define CP and the criteria required for a diagnosis, explain the risk factors, the diagnosis warning signs, list of assessments, tools to assist with the diagnosis and classification of CP, and then also explain evidence-based therapy interventions that are going to improve function and participation. So let's get into it. What is CP? And I don't know how many of you guys are familiar with CP, so we're going to start with a very basic definition of it. Is an umbrella term that describes a group of disorders of the development of movement and posture causing activity limitations that are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. So breaking that down, the key things here are fetal or infant brain. So 2 years or younger is common practice. And if there's one thing you guys take away, that is understanding CP is non-progressive. So it is a permanent disease, but that means that the brain injury will not produce further degeneration of the brain. And here is Dr. Peter Rosenbaum, who you will hear his name a lot. He is great, has done great work and great research. So here's his explanation of CP.
Hello, my name is Peter Rosenbaum. I'm a developmental pediatrician at McMaster University in Canada. Cerebral palsy refers to a group of conditions that are caused by problems in brain development and that affect how movement and motor control happen in children. Problems with walking and talking are often the way people start a conversation about CP. There are things we can do to enhance both walking and talking, but we most particularly want to help people be able to be independent in their mobility to the extent possible and able to communicate, even if that means using other ways than their voice. Cerebral palsy is thought of as a developmental disorder because it affects children's movement, and movement is fundamentally important to all of learning. The things we can do to help parents and help kids are to promote activity, not worry about whether it's done nicely, but make sure that kids have lots of opportunities to explore, to experience, to do things in whatever ways are useful to them.
All right. So kind of understanding the causes of CP. So again, CP is related to brain damage, and it's going to occur before, during, or after birth. So meaning prenatal, before birth, it may be hereditary, genetic, cause of infection, anoxia, which is loss of oxygen to the brain, metabolic disorders, and intracranial hemorrhage, which is going to be bleeding into the brain's ventricular system, and that could be due to physical trauma or bleeding during a stroke. You have perinatal, which is during birth. So that could be prolonged or difficult labor, or just prematurity, being born early, as well as postnatal or after birth. Again, those vascular accidents, intracranial hemorrhage, as well as trauma infections. And just to really highlight, this is 2 years or younger. So how common is CP? CP is the most common motor disability in childhood in the US. It's about 1 in 345 children in the US, and prevalence worldwide is about 1 to 4 per 1,000 live births. And just to note, increased prevalence of CP for those who are born preterm or at a low birth weight, as well as CP is typically more common among Black children than white children, and Hispanic children and white children were about equally likely to have CP. So I think this is probably one of my favorite diagrams that we will show you today, because it really highlights that while CP originates with a brain injury, it's really going to affect, or it could affect, the musculoskeletal system. and it's going to impact many body structures and functions. Therefore, it's going to be best managed by a multidisciplinary team. So where we all come into play by treating CP. And here you can just see, Iona Novak really highlighted pain as the first one there. And I think that might be the key here. If you see 3 and 4 children with CP are going to have pain. And then having pain can also lead to sleep issues and behavior disorders. And you can see behavior is 1 in 4 children. And having pain behavior, and then you look at they're 1 in 4 are nonverbal. So it all kind of correlates together of really highlighting how they can play onto each other. So having a multidisciplinary team converting and talking through this can help have better treatment. And then another diagram, and you will see we love models here at OTPT. This is International Classification of Functioning, and we'll refer to it as the ICF model. And it really takes the health condition and then breaks it down to looking at the body, activities, participation, and looking at how environmental and personal factors correlate with all of that. And again, just kind of looking, before this model, we really used a bottom up or a narrow approach. And this really is looking at the whole child and the whole situation versus looking at just the health condition and kind of putting it on the disability.
So research has found that there's some different detectable risks of cerebral palsy early on in life. This is really important because these are specific types of red flags that we are able to screen for both during our OT and PT evaluations and treatment sessions, but they can also be evaluated at well-child visits with their physician or other care providers. So there are some very specific red flags and abnormal movements that make someone more at risk for CP. This diagram shows, based on age, what these different impairments may be like, including past the age of 4 months, if we are seeing any persistent hand fisting or persistent head lag. That is where when we pull them up to a sitting position, their head falls back behind them. With past 6 months of age, if they're not supporting their weight when they're placed in standing, past 9 months of age, if they are not sitting up independently, between 6 and 12 months, if they have any stiffness in their legs. And then finally, just in general, watching for asymmetries. If they have a hand preference before 12 months, this is a sign of possible cerebral palsy, or any asymmetry in posture or movement. So if they are using one side more than the other. And then all of these help us to know if we need to refer to something called IMEC. This is the Infant Motor Evaluation Clinic at Cincinnati Children's, where they are able to further assess risk for cerebral palsy. So again, the big role for OT and PTs in this process is that we are often some of the providers that notice these things first, because we are seeing these kiddos so often. Another characteristic that we're watching for is something called abnormal muscle tone. So muscle tone is where we have the muscle either be very tight or very loose. The tightness can kind of lead to postures that are kind of close together and they aren't able to move joints as freely. And then what is called hypotonia is low tone. That's where the baby may be a little bit more floppy. Their muscles might be a little bit more flexible. And again, we're just kind of watching for these delayed motor milestones and red flags and referring as needed. So there are some different assessments that can help predict and diagnose cerebral palsy. The first one is the general movement assessment, where we can do that from birth to 4 months of age. The infant is actually recorded for 3 to 5 minutes and then assessed by a physical therapist to see if they have any absent what we call fidgety movements, which can show a higher risk for cerebral palsy. Then we can also complete the Hammersmith Infant Neurologic Examination, which is we usually call the HINE. This can be done from 2 to 24 months of age. And when we say corrected age on this slide, this means that if the baby was born early, earlier than 37 weeks, we are able to subtract that time out and base their age on if they were premature or not. And then we can also use magnetic resonance imaging, or MRI, to look and see if there is some form of injury to the brain. So I do want to kind of highlight that actually the combination of that GMA assessment and the HIND is actually more specific in its ability to diagnose cerebral palsy than what we call a positive MRI by itself. So when I say a positive MRI, I'm kind of noting that there is something wrong that we're seeing on the MRI image. If there's some form of bleeding or some abnormality within the brain, we're seeing it there within the positive MRI. And this is really important because some infants can have a normal MRI, so an MRI that is not showing any injury to the brain, but still be diagnosed with CP. And this is because if the MRI was taken at a time where the injury wasn't becoming present, we could kind of miss it. So this is a very important part. So why is it so important that we are diagnosing these things? It's because this early diagnosis can lead to more appropriate treatment, which I'll be going into more in the next slide. But as science progressed, we are able to diagnose cerebral palsy at a much earlier age, as young as 3 to 6 months of that corrected age. When the baby is before 5 months of age, we are able to use the MRI plus the abnormal GMA or HIND. And after 5 months, we're able to use the MRI, HIND, and then the developmental assessment of young children. So as I alluded to in the previous slide, this is really important because this earlier diagnosis leads to earlier appropriate intervention that the child needs to optimize their motor and cognitive neuroplasticity. So neuroplasticity is the time period up to 2 to 3 years of life where the brain is very malleable and flexible to both good and bad changes. So during this time, the brain is forming new connections, it's changing, it's taking out things that aren't as needed. And by supplying early interventions during this time, we are really able to optimize what progress we can see even later on in life. One of our colleagues actually, when we were discussing this PowerPoint, brought up the quote that early intervention helps map the brain. And if we actually do it later, you have to instead rewire and change that map. And I thought that that was a really great analogy for that. So how we classify cerebral palsy. So we have a multitude of different ways of doing this, both from a PT standpoint and an occupational therapy standpoint. The first being topography. Then we're also looking at their muscle tone. And then we also have some different scales that we'll be going through in the next slides. Okay, so this email, this video is going to go over the more of the body distribution of the impairments in cerebral palsy. And I think it gives a really nice highlight.
One of the things as a physician that is really important is to really try to understand the brain injury for each person, because they can be really different and they really give important clues to what are the motor problems for cerebral palsy for that individual. Did you know that the time you have the biggest risk to having a stroke is as a baby, not as an adult? And if you have a stroke to one side of your brain, it can lead to problems sending clear messages to the other side of your body. We call this hemiplegic cerebral palsy, and it can be either on the right side or the left side. One of the important types of injury is a pattern that we see when we're born prematurely or early. And this particular baby is then at risk to have an injury in the area of their brain that runs right beside the fluid-filled spaces. This particular type of cerebral palsy is called spastic diplegia, difficulty moving your legs and having increased tone or stiffness in the muscles on both sides. If you have an injury to both sides of your brain, then you have difficulty sending a clear message to both your arms and your legs, and we call that spastic quadriplegia. And sometimes this is associated with a more significant physical disability. When a baby is born and there's an acute decrease in oxygen or blood pressure, the baby sometimes injures a really important part of the brain called the basal ganglia. What this can lead to in terms of cerebral palsy is a type of cerebral palsy called dyskinetic cerebral palsy. One of the key features of this type of cerebral palsy is a real fluctuation or change in the amount of stiffness in the arms and the legs. Another really important part of the brain is called the cerebellum, and it helps us balance. And sometimes individuals with cerebral palsy can have an injury that involves the cerebellum and leads to problems with balance. We call that ataxic cerebral palsy. One of the biggest misconceptions I find for individuals with cerebral palsy is the public generally thinks that CP is all the same. It's really important to think about the complexities of the brain and the injury, and each individual with cerebral palsy is affected differently. So you really need to take each person as they come, look at their strengths and weaknesses, and go from there.
All right, so I think that that gives a really nice highlight of that type of distribution. So this is another infographic on the types of distribution of cerebral palsy. So a child can have something called quadriplegia, which is in this top left corner, where all limbs are affected and their trunk is affected. So when I say affected, that means that they may have tightness or weakness. There are impairments in these areas. They can also have what we call diplegic cerebral palsy. That's where both of their legs are affected. And then hemiplegic cerebral palsy, where they have one arm and one leg on the same side that is affected. And we can have about 39% of cerebral palsy is hemiplegia, 38% is diplegic cerebral palsy, and 23% is that quadriplegic cerebral palsy. So next we will be watching a video on the types of gait that we sometimes see in these kiddos. This first one is for hemiplegic cerebral palsy. So this little girl has weakness on one side of her body.
Go ahead and walk. Now walk back to the wall. And say walk back to the middle. And then walk over to the other side. Yeah, that side. There you go. And then walk back over here to this side. And then walk back over to the other side. And then walk back to the middle. And we're done.
So you can kind of see in that previous slide that she is using one side less than the other, where she's kind of having to bolt up on one foot. That is due to having some weakness on the right leg and having some issues with clearing that foot. Next, we will be looking at a video of just the first 24 seconds of this one of a child who has quadriplegic cerebral palsy. So as you can kind of see here, his knees are kind of coming in together. He also is kind of staying up on his toes, and you can kind of also see that his arms are also involved, where the caregiver is having to assist them while they are walking. So we can also classify individuals with cerebral palsy based on their type of muscle tone. So as I discussed on a previous slide, you can either have high tone, which is hypertonia, or low tone, which is hypotonia. Hypertonia can be further distinguished into 3 different types, where spasticity is the first one, and that is where when we do an increased speed of a movement of a joint, that we have increased resistance. For rigidity, it is not velocity dependent, so it does not matter how quick or slow you move the joint, they still have that tightness. And then finally, dystonia is an uncontrolled movement that is involuntary and very repetitive. We will have a video of what dystonia looks like on a following slide. We can also base the cerebral palsy based on the type of movement they have. So dyskinesia is the medical term for uncontrolled movement, and that can be further broken down to athetoid and ataxic movement. Athetoid is a slow writhing movement that occurs, and ataxic is where they have more impairments with their balance and motor control in general. And this usually results from injury to a part of the brain called the cerebellum, which really involves the control and motor control part of movement. And then finally, we can also have dystonia. So we won't be watching the full video of this video, but this gives a great example of what dystonia might look like in a child who has CP. So that gives a really great example of how dystonia may look like in a child. And we will need to exit out of our PowerPoint really quick because this next video is a little bit larger. Okay. Share something, right? Yeah, okay.
The Gross Motor Function Classification System, or GMFCS, describes 5 levels of gross motor function for children and youth with cerebral palsy. It focuses on abilities, what people do in their everyday lives, and is based on meaningful activities such as sitting, walking, transfers, and wheeled mobility. Emphasis is on participation in home, school, and community settings, rather than best performance in clinical situations. A classification is made by determining which level best describes current gross motor performance in daily life. The GMFCS has age-based descriptions as motor function changes with age. The original GMFCS had 4 age bands: before 2nd birthday, between 2nd and 4th birthdays, between 4th and 6th birthdays, and between 6th and 12th birthdays. The Gross Motor Function Classification System, expanded and revised, or GMFCS-ENR, includes an age band for youth 12 to 18 years of age. The system is ordinal, with levels ordered from more able to less able. The difference between the levels is not considered equal, and children with cerebral palsy are not distributed evenly across the 5 levels. The general headings for each level are based on the method of mobility most characteristic for children after 6 years of age. Level 1, walks without limitations. Level 2, walks with limitations. Level 3, walks using a handheld mobility device. Level 4, self-mobility with limitations, may use powered mobility. Level 5, transported in a manual wheelchair. Children functioning at Level 1. Walk without limitations, at home, school, outdoors, and in the community. They sit with their hands free to play and can get in and out of a chair without using their hands. They can go up and down curbs or stairs without the use of a railing. They can walk wherever they want, on uneven surfaces, slopes, or in crowds. They can run and jump. However, speed, balance, and coordination may be limited. participation in physical activities and sports depends on personal choice and environmental factors, such as level of competition. Children functioning at level 2 walk without walking aids in most settings, but may experience difficulty with long distances, uneven terrain, inclines, crowded areas, or carrying objects. Running and jumping are challenging throughout life. Children move from the floor to sitting or standing if there is a stable surface to push or pull up on, and can use their hands for play when sitting in a regular chair. They climb stairs holding onto a person or railing. Younger children can crawl on hands and knees with a reciprocal pattern. A walking aid may be used by young children when learning to walk, or by older children or youth in community or busy settings. When traveling long distances, wheeled mobility is often used. Adaptations to activities or equipment may be necessary to enable participation in physical activities or sports. Children functioning at level 3 walk using aids such as walkers, crutches, or canes. Most children use a variety of methods for mobility, depending on their environment or preference. They often use a wheelchair when traveling in the community. They may walk up and down stairs holding onto a railing with supervision or physical assistance. When sitting, a seatbelt may provide pelvic alignment, balance, and optimal hand function. Moving in or out of sitting requires physical assistance or a stable support surface. Younger children can creep on their stomach or crawl on hands and knees, but without reciprocal leg movements. Participation in physical activities and sports may require adaptations, such as special equipment, wheelchairs, or power mobility. Children functioning at level 4. They are mobile for short distances through rolling, creeping, or crawling. Can maintain sitting if positioned, but require adaptive seating for trunk and pelvic control and to maximize hand function. Physical assistance from 1 or 2 persons is required for transfers. Weight may be taken through their legs. They can walk short distances with physical assistance or a body support walker. Children are physically capable of using power wheelchairs. If power mobility is not feasible, they are transported in a manual wheelchair. Participation in physical activities and sports is possible with physical assistance and/or powered mobility. Children functioning at level 5 are limited in their ability to maintain hand and trunk control or move their arms and legs with any age, are transported in manual wheelchairs. Transfers require lifting or the use of equipment. Assistive technology is often used to improve head alignment, seating, standing, and mobility, but limitations are not fully compensated by equipment. Some children may achieve self-mobility using powered mobility with extensive adaptations. Participation in physical activities and sports is possible with physical assistance and adaptive equipment. Sometimes, the distinctions between 2 adjacent levels are subtle. Children need to be able to do everything described in a level in order to be classified in that level. Most, but not all, children will remain in the same GMFCS level after the age of 2 years. Children classified before their 2nd birthday should be reclassified when older, as their level may change as their abilities become more apparent. The GMFCS can be used to describe adults with cerebral palsy. Their level of gross motor function can change over time due to social and environmental factors or aging, and they may need to be reclassified. The GMFCS can be used by health service providers familiar with the gross motor abilities of children with cerebral palsy. The GMFCS ENR Family Report Questionnaire enables parents to classify the gross motor abilities of their children 2 years of age or older. The GMFCS ENR Self-Report Questionnaire allows self-classification for young people 12 years of age or older. The GMFCS has been translated into 22 languages and is used around the world as a common language for clinical practice, research, teaching, and service delivery. In clinical settings, it facilitates communication with families when discussing gross motor prognosis, setting realistic goals, and planning appropriate interventions. Understanding future needs can help families make decisions about transportation, housing, and accessibility. The GMFCS is used extensively in research to select, describe, and stratify participants. There is good evidence of stability, reliability, and validity when classifying people with cerebral palsy. However, the GMFCS is not intended as an outcome tool to measure change in gross motor function over time. The GMFCS can inform service delivery decisions, such as caseload management, resource allocation, and facility development. Detailed descriptions of the gross motor abilities for each age band in the 5 GMFCS levels are available on the CanChild website. The development of this video was made possible by the support of CanChild Center for Childhood Disability Research.
All right, thanks guys. So I really love that video because it actually gives you guys a good visual of what the different varying abilities these kiddos have. So this is just an infographic to describe the different classifications the video reviewed, where GMFCS level 1 is the least severe and GMFCS level 5 is the most severe in terms of motor challenges for these kids.
All right, and then moving on, there's going to talk about the MACS, which is the Manual Ability Classification System, and we use this more in OT, where we're really looking at the manual skills and how children or individuals with CP utilize their hands in daily activities, but most importantly in their natural environments. It is from 4 to 18 years, and then we also have a mini MACS, which is ages 1 to 4. And what I like about this is it's also following the GMFCS because it's from 1 to 5. 1, they're handling the objects easily and successfully. 2, 3, and 4, they're kind of looking at how there might be limited quality, or it might take them longer, or they might need someone to put the object in their hand and then they can manipulate it. To 5, not using it or has severe limitations. And it's also really important when we're looking at the MACS to consider their vision and cognition, because that's going to impact their level as well. And then moving in, the eating and drinking ability classification system is a little bit newer. I actually recently learned about it when I was in our feeding clinic, so I don't know how familiar anyone might be with it. Our speech friends might know about it. It is from ages 3 to adulthood. They also have a mini eating and drinking ability classification, which is 18 to 36 months. And same kind of concept here, you're moving from 1 to 5. 1, they're able to eat, drink safely. And the key with this one is 3, 4, and 5, we're really concerned with safety and choking. Mentioned earlier, some of these kiddos with CP may have dysphagia or difficulty with swallowing. So looking at that safety effect, 5, they will possibly be having a tube placed for CP. And our last one, I think our speech friends might know a lot more about this than me, but there is a communication function classification system. And this is really just identifying how they're sending, receiving communication, but also the pace that they're at. And what I like about this is it's not just speech. They can be using an AAC device. And it, again, consists of those 5 levels describing communication and their everyday abilities, as well as looking at if they're familiar family members, but also kind of with unfamiliar environments as well.
All right, so now we are going to move into the portion of the PowerPoint where we discuss our evaluations from both a PT, physical therapy, and OT standpoint. So as Kelly previously wonderfully explained, we like to use the ICF model in order to look at the child as a whole person rather than just their impairments. So typically how we start our evaluation is we discuss a patient or family interview. Prior to completing the rest of the evaluation, we ask about birth and medical history. This will help us to know about if they had any birth trauma at any young age, and if there are any risk factors for developing cerebral palsy if it's not already diagnosed. By discussing their development, we are also able to gauge if they were grossly on target for their gross motor skills, which again is those big movements we've talked about in ITT, like crawling, sitting, and walking. As Kelly has suggested before, pain is also important to discuss due to 3/4 of children having pain. So I will also ask that during my subjective interview as well. So then going more into my evaluation, first we look at the individual based on body structure and function challenges or impairments. First being, we look at their posture. So we want to make sure to assess the child or individual at multiple parts of their body, at their trunk, hip, knees, and ankles, both in sitting, laying down, and standing. So we want to make sure to look at their postures because sometimes when their muscles have that higher muscle tone, they may be tighter. And this causes some joints to not be as flexible and be held more in a static position. We'll also look at range of motion, which as you can see in this picture here, that is called a goniometer. We use that to make a quantified number for the range and how much their joint can move. And as I discussed on the previous slide, we also rate if they have hypo or hypertonicity. We do have some standardized assessments to do so as well. And we also look into if they have something called selective motor control. So these individuals with cerebral palsy often will move their entire body when they try to move only one joint at a time. So this can really affect their functional ability to complete movements. And we want to quantify and see how able they are able to do so, or if they have more challenges doing this. Then we also look at strength. So this is typically used through a manual muscle test. As I'll demonstrate on Kelly, I would have her try to bring her arm in towards herself, and I would tell me, don't let me move you. And we would see how strong she is. This is a typical way we do this in physical therapy, but with kids who may also have some cognitive challenges, this can be difficult to follow. So we also look through functional strength. So as physical therapists, we can hypothesize what is strong, what might be weak, watching them on the stairs, how they get in and out of a chair, and so forth. And then we also assign the GMFCS level that was explained in the previous video. We then look into the activity limitations. So this is important to see what they are limited in based on their activities. So we look at the functional mobility of how they are getting in and out of bed, how they are getting in and out of a chair, how are they walking, and how are they managing the stairs. So there are a few common things we see when they're walking that can be more challenging for children or individuals with CP. They may walk on their toes. They may walk with their knees kind of pointing in with their toes inward as well. Or they can have something called a crouch gait pattern where their knees are constantly bent. We can also do standardized assessments, include timed walking test and something called the observational gait scale. I also will look into their coordination in general, see if they can do things like hopping on one foot, can they do jumping jacks, can they skip or gallop? And then finally, we look at just general gross motor skills. Can they catch and kick a ball? Are they able to jump? This will come into play when they're playing with their peers and at recess. Then finally, what's really important is asking them about their participation. So when I first meet a family and patient, I make sure to ask about really what their primary concerns are and what they hope to get out of physical therapy, mainly from a participation point. Do you want them to be able to be more independent going through the house? You want them to be able to participate in this adaptive sport, because patient and family reported goals should always be the forefront of our concerns. So we'll also discuss what access do they have for community supports and programming. And if they don't have that, it will be in my plan to provide that through our interventions. Then finally, we also look into their environmental associations. So we'll want to see if they need new equipment or it needs to be grown. We'll be going into more detail in equipment in our next presentation. We also look at orthotics, which those are here. These are different types of braces that can help with walking pattern and providing passive stretches to their feet and their arms. And then we also want to look into seeing how much family support they have. Will the family be able to help them get to appointments? Are they able to physically assist them with completing transfers? And finally, as I've talked about in our ITT meetings, home layout is important as well to see what kinds of things they're navigating, like stairs, steps, do they have a ramp, and so forth. And then finally, we have one examination called the gross motor function measure. And it's very important because based on their classification from the GMFCS, we actually have curves that were developed through research to monitor their progress towards their gross motor skills. So this test looks at children in a few different domains, such as lying and rolling, sitting, crawling, kneeling, standing, walking, running, and jumping. And it just really allows us to monitor their progress in a numerical way.
All right, and then kind of going into the occupational therapy evaluation, it may kind of seem similar to the PTs. We do a lot of the same structure, but we're looking at very different things. And I think Kim did a great job of highlighting that when we're considering creating this occupational profile of looking at their performances, the home layout, their daily activities, we also just really want to know what they want to work on specifically, or what are their main concerns. And we're again using that ICF model to really get that whole picture and do that top down approach, or top up, top down. Yeah. Okay. Sorry. And always asking them their history and then going into what their concerns are right now. So Kim also talked about body structure and function. Again, we're going to look at that posture and their positioning, whether they're in a wheelchair or just sitting in a chair while they're standing. Looking at their range of motion, the muscle tone, the strength. We also do the manual muscle testing. Again, we're looking at different muscles when we're doing our testing. And then in OT, we're also looking at their grip and pitch straight. And then again, asking about pain. And then one thing OTs do as well is we look at vision. So as highlighted, I think it was 1 in 10 may have blindness, but they could also have cortical or cerebral visual impairment. And that is a disorder caused by damage to the parts of the brain that process vision. And it's vision problems that can't be explained by the eye. And we are going to learn more about that in our EB case discussion next week. And then the reason we're really looking at vision is they might be having difficulty reaching, or they're disregarding visual stimulation, and they just might not have purposeful eye movement, and that's going to impact their activities of daily living. So then we're going to create that occupational profile. So really, again, looking at what the patient and what the family wants and what their life experience has been up to this point and what brought them in for services. We're going to also look at the home layout, and then we're going to assess equipment within the home. Do they have any barriers to functional mobility or equipment use? What kind of supports do they have? Do they have a lot of family? Did they move here just for services? They have respite coming in and out of the house. Do they have nurses or other care providers? Really gaining that picture is super valuable to understand how we might pull other medical providers in or connect them with social work to give them those supports. Identifying those barriers, and then life roles, understanding if they're a student, a sibling, an employee, and how we can support them. And then we're going to look at their client factors or performance skills. So considering their upper extremity functions in the context of activities of daily living. So dressing, bathing, feeding, those instrumental activities of daily living. So their chores, running errands, participating in the community, their play and leisure. What do they enjoy doing? What is impacting their enjoyment of play? Education, are they going to school? Are they homeschooled? Are they having limitations? Are they working? Do they have social participation concerns or wanting to improve on that, as well as sleep? I know we talked about sleep being a big one as well for them. While also looking at upper extremity function, we're also going to consider their cognition, their vision, their behavior. All of that is going to impact how we proceed. So now that you kind of have an idea of what we're doing in the evaluation, once we gather all this information, we're going to recommend either starting an episode of care and moving into interventions. And that is going to look like this. Oh, no. You just have to, there we go.
Go get them! Come on, let's go get the turtles. Good.
So anything we can do that's combining both hands and both feet is really good because his left side is weaker.
Right, buddy?
Or yellow ball. Red or yellow? The yellow one? The red one? Those are his eyes. Eyes and
So that was just a highlight of what we're doing at Cincinnati Children's, and we'll go into more detail about some of those interventions in a little bit. But always wanting to go back to this ICF model, I'm sure you guys will be sick of it at the end of this presentation, but I like this one specifically because we're taking that health condition of cerebral palsy and again, making it that whole picture of looking at those body structures. So their tone, their pain, their muscle control, their strength, those activities, handwriting, self-care, gross motor, walking, running. And then what participations do they want to do? Do they want to be on a sports team? Do they want to be able to participate in school activities or even just running around on the playground? And then again, looking at those environmental, what equipment are they using? Do they have an IEP or a 504 plan? Personal is like age, their gender, their family, their self-esteem. And that's one thing we haven't highlighted yet, but also taking in mental health and the psychological factors that come along with CP and other health conditions. And just being mindful of, we want to show them that they can do these things and they can do it independently or to the best of their ability. So giving them that kind of boost of confidence is also a goal that we have. So for OT and PT, we really just want to increase that activity performance and improve participation so that they aren't coming to therapy and that they're in the community learning the skills that they learned in therapy. So we always want to use evidence-based interventions because we want to rely on the research that has shown success. So CP is a chronic condition that it is going to extend across the lifespan. But again, just really highlighting that this injury is not progressive. So it could look that way because as they're aging and growing, that their muscle length and their strength and things are going to change over time, but it is a non-progressive disorder. But really looking at children's, we highlight the episodes of care. So they might need therapy throughout life, but it's so important to take those breaks and not just come into therapy every single week or every other week. So kind of highlighting that as I was talking. We've gone through the evaluation. I'll go into a little bit more detail about how we do our goal setting. And then we're going to hit that episode of care, that focused treatment on what the patient or the parent's concern is in that moment. And then after that episode of care that could last 12 to 16 weeks, we kind of assess our progress and see, did we hit those goals? How might we need to readapt or change what we are doing in therapy? But if we hit them and everyone is happy in that situation, I think it's always awesome to be able to take those therapy holidays or those breaks and kind of give the child time to adapt to their real life situations, because it's great to be in a room 1 hour a week working on stuff, but where you're really going to see those changes is at home and in the community. So I highlighted the goal setting a second ago, but we use a Canadian occupational performance measure at the beginning of our episodes. And it's really kind of looking at teamwork with the family and the kids. If they're old enough that they can communicate, I really ask them, like, what do you want to work on, or what's the struggle right now? And they identify those goals or those problem areas. And then we have them rate based on their satisfaction and performance level on a scale of 1 to 10. And that could be self-care, leisure, functional mobility. And then we save that. And then at the end of the episode, those 12, 16 weeks, we kind of revisit those areas and have the parents or the patient rate them again and see if there was any significant change in those goals. So it's just a great way for us to track progress and make sure we're hitting those goals. And again, it establishes participation from the ICF domain.
All right. So next, as Kelly suggested in previous slides, we really want to make sure that we're using evidence when we're considering these treatments, because we want to make sure we're using the best possible findings for these kids. So there is a researcher named Ayana Novak who has created this paradigm for OTs and PTs to use called the traffic light system. She has gone through and, based on the evidence, rated each intervention as green, yellow, or red in terms of its effectiveness for providing intervention for individuals with CP. So the green light is do it. Evidence supports this effectiveness in children with CP. Yellow would be probably do it, but let's really measure the outcomes to make sure it's beneficial since there's inconclusive or lower level evidence in children with CP. And then red is do not do it because there's either no evidence to support or another intervention exists that has shown to be more effective. So we will not be going into all of these in high detail, but these are some of the examples of some of the green light interventions from an OTPT standpoint. One that we probably won't highlight too much about the following slides is hippotherapy. That's actually where the child is on the horse, and as the horse moves, they have to control their core strength. We can also work on strength training and mobility training and PT, but again, this just really provides a nice guide for therapists to use. And then the yellow light interventions, that's the maybe do it, probably do it. We have things like mirror therapy or yoga, utilizing co-op, things like biofeedback, and just general physical activity.
And again, going back to our visuals and diagrams, this is what is used in the study. It's probably very overwhelming and we don't expect you guys to really learn much from this, but we love it because it breaks it down from the green, yellow, and red. And just the larger the circle means the more evidence and research supporting those interventions specifically.
Okay, so one of the specific interventions that we will be going through is something called serial casting. So these casts look a lot like the casts that you would see on a child who's broken their arm or leg, but instead of providing protection to a joint, it actually is used to increase passive range of motion, so how much stretch there is. So during this time, a child receives a series of casts, as you can see in this picture, where we gradually increase the stretch, and then they wear it for on a weekly basis. And then it's kind of almost like braces, like in your teeth, you slowly get them adjusted and your body acclimates to it. It improves range of motion, which is what ROM stands for. It tends to improve function. And we also like to say it does not limit the child when they have the cast on. They still can run, jump, play. Sally has even told me about patients who've hoverboarded with serial casts on. And in general, this is a yellow light intervention. Next, we have something called treadmill training. So that can either be typical treadmill training or something with partial body weight support treadmill training. Using the treadmill is really helpful because we can change the speed, the incline to either work on more power movements, or if we want to work on increasing step length or just overall walking speed, it can be a really great challenge for endurance and strength as well. We use the partial weight body weight support system when a child has some decreased trunk control or they may need some additional help with walking. It's really nice because we put them in this harness-like system, and that provides enough support at the core, and as physical therapists, we're actually able to move their feet in a more typical walking pattern.
All right, and then moving in to CIMT and VIMT, which the video quickly highlighted. CIMT stands for Constraint-Induced Movement Therapy. And again, it's an intervention which we're going to constrain and use the unaffected hand and then really hit that affected hand. So let's say they're weak on the left side. I'm going to block their right hand that they typically might use more often and really force them to use that left hand when doing tasks like playing games or opening and closing containers, whatever we want to work on. I think the child in the video was eating, so having him use their hands to eat, all of those things. And so it usually we'll start with constraint of just blocking the one hand and then move into BIT, so bimanual both hands. And we really just want the patient to improve their performance with both of their hands. And again, having them maybe hold that container and open it, stacking blocks, really just getting them to kind of like realize that they have that other hand there. And I will say it is intense therapy. We're doing 6 to 8 treatment sessions, but then it's a lot of carryover at home, and the parents or caregivers are expected to have them wear the cast daily and really working on it. And it's not always fun for the children, but it will pay off in the long run. And then the next one is goal-directed activities, and this is also a green light intervention. And I just love this because it is just practice, practice, practice. The point of coming to therapy is we're going to rehearse those activities, but they're specific to the goal. So if I want a child to be able to button their shirt, we're going to work on buttoning. Or if I want a child to brush their teeth, we're going to work on brushing our teeth because that's where we see the most success. So always practicing the entire activity sequence and focusing on one step at a time as needed. So breaking down the task and then having them practice the whole thing. Really engaging in those cognitive strategies. So co-op, we learned a lot about co-op, the cognitive orientation to occupational performance that they highlighted in the DCD lecture. And it's just, we really want the kids to come up with the ideas and the wording because we want it to make it their own so they'll remember it. If I'm telling them, go to the top, they might not know what the top is. So having them come up with their words, then they'll remember it and use it in their daily lives. So going back to that goal, plan, do, check, and having them come up with a plan and the sequence on their own is huge for the kiddos. Another thing we wanted to highlight is OT, PT, the wellness programs. So while we work really hard during the evaluation intervention, the whole goal is those kids to get out in the community and increase their participation and their social engagement. So we really encourage them to get involved with Be Well because not only is it great for the kids, I think it's also great for the caregivers. You get to meet other family members and share stories and create lifelong friends. And the Be Well program is actually what made me really want to become an OT. I volunteered in the aquatics program in high school, and it was just the highlight of my week. There's so many unique experiences. You can rock climb, running club, adaptive tricycle or bicycle, as well as, I don't know if I said ballet, which Kim and I do on Saturdays with Michelle, and we love it. There's also, I think, yoga and meditation. So just such a wide variety of programs that we offer families that we really encourage them to use. So kind of taking a step back and going back to the beginning of how we talked about, this is a multidisciplinary approach. It cannot just be done with OT or PT. It really takes a whole team. And one thing I love at Children's is we have so many different clinics that offer that for families. So looking at the surgical spasticity clinic, which has PM&R, which is physical medicine and rehabilitation, which their really specialty is restoring function, as well as there's a neurosurgeon and a PT there. So they're all there collaborating. We have CP clinic, which has PT, OT, the physical medicine, social worker, dietitian, and a nurse. Kim highlighted the IMEC clinic, or the infant motor evaluation, which has the MD, PT, and social worker. The CVI clinic, which we highlighted vision, ophthalmologist, and OT, and then teacher of students with visual impairment, which I thought was interesting. Those are educators who have been specially trained to work with students who are blind or have low vision. So they're not specifically therapists, but they are teachers, which I think is awesome to have in our clinic. We also have ortho hand clinic with the OT and MD, ortho CP clinic, which is the PT and MD, as well as a wheelchair clinic. So you're going to have the doctor and then possibly an OT or PT with them.
So now we will be discussing the medical management of cerebral palsy. I do want to give the caveat that this idea could be a whole presentation in itself, so we will just be giving a little summary of it. So one way that doctors can help manage spasticity in an individual's muscle, that's again that tightness of movement when it's moved quickly, is using something called Botox. This is actually the same chemical that is used that some people put in their faces or in their skin to decrease wrinkles, but it is, the formal name is botulinum toxin, which is a common medical intervention used in CP to decrease that spasticity and help the muscles relax. And it has been found that when it's combined with OT intervention overall, it can improve motor activity muscles and has been highlighted as that green light intervention. It can mainly usually supplied through injections, which is really helpful because then you can just isolate one area of the body rather than affecting the entire body, which can be helpful when in a case with hemiplegia or only one part is affected. Then there are some surgical management that we can do to assist with spasticity, one being an intrathecal baclofen pump. Baclofen is a similar skeletal relaxant chemical, which it can be surgically implemented and then has to be refilled on a regular basis and can provide that relaxing stimulant to the child or individual's muscles. It has been found that PT may be indicated after a surgical baclofen pump placement, but not always. And then there is also something called a selective dorsal rhizotomy. So in this, a neurosurgeon actually goes in and cuts some of the rootlets of the that come off the spinal cord, as you can see in this picture. The rootlets or nerves is what controls and gives information to the muscles. So when they are cut, it allows the muscles to relax. Now, this type of intervention does require intensive physical therapy following the surgery for up to 5 days a week for 12 months, because at times they can find that when the spasticity is gone, it uncovers some muscle weakness and they have to relearn how to do different gross motor skills from a PT standpoint. And these are both yellow light interventions. Other surgeries that we sometimes see in cerebral palsy include muscle tendon lengthening, muscle reattachment, and osteotomies, which is cutting and reshaping the bone. So this usually is done because of some of those postural abnormalities. We see it in kids. Sometimes the muscles behind their knee can be tight. Sometimes the muscles in front of their hip can be tight. That can affect their function and posture. So in order to decrease the number of total surgeries overall, they can complete what we call a single event multi-level surgery, which is coined a SEMLS. This is where they make multiple of these corrections to the muscle and bone, all within one single surgery. This results in having less surgeries overall for the family and the kid. And it is also indicated to have an intensive PT intervention following the procedure in order to strengthen muscles and relearn certain gross motor skills. So this is actually the end of our first presentation today for cerebral palsy. We have really enjoyed talking with you guys so far and would love to answer any questions you have at this time. And you are free to come off mute if you have a question.
I know, Jason, we tried to highlight some of your questions, but feel free if we missed anything. Yeah.
Well, and oh, sorry. Yes, Andrea.
Hi, ladies. Thank you so much. This was very, very informative, and I really, really appreciate this because I haven't had this in my training. I do have a question, probably not related specifically to what you were presenting, but related to CP. So I, unfortunately, we do work with people in low resource settings abroad, and recently diagnosed 2 kids with CP back in Guatemala via telehealth. Limited resources, no physical therapy, no need, very hard to get MRIs and things like that. When an MRI change any kind of intervention on outcome at this point? So I should be fighting to get one. Do you guys have any recommendations with that question? And then the other one, it seems that, physical occupational therapy are like a big part of, their success and prognosis with CP. Do you guys have any guides by any chance that can be given to parents so they can do therapy at home? So, they can maintain all these therapies. I'm just wondering if I could use any of those resources and maybe send it abroad, and I would really appreciate it if you guys have any input or any guidance.
Yeah, sure. So just to clarify, for your first question, you're wondering if it would be helpful to have an MRI later on after there's been a diagnosis, just to clarify.
Yes, like, would it be of any need? I feel that it wouldn't change anything at this point to get an MRI.
It depends on their age. So Christy actually asked a somewhat similar question in the chat. So kids can still be diagnosed with CP after 2 years of age. It's just that we have to make sure that the potential neurologic insult occurred before 2 years. So they can be diagnosed at 4 years of age, and we can kind of, sometimes those misses do happen, or they just haven't been seen by a doctor. But the important thing is we need to be able to track it back to something that happened around birth, or some of our imaging practitioners may be able to look at time-based things to see how long ago an injury occurred. And when it happens after, then you actually consider it as a traumatic brain injury. I think that if they already have a diagnosis of cerebral palsy, I don't know if it would make that much of a difference. The big emphasis is that if they are at risk for CP, or if they were diagnosed previously based on other assessments, that they are receiving the interventions at the best of their ability. But with the caveat of being they may not have those resources. And I think Kelly was gonna kind of jump into the second question.
Yeah, just regarding resources, I know TPT, we have a lot of knowing notes on CP, and I think it would be awesome if we could send you some of those and maybe you could send them across. I don't know if that would be something. It kind of goes over diagnosis and some of the treatment and interventions we use in guiding interventions. I'm also more than happy to connect you with some of the articles that we use to create this that kind of highlight our interventions.
Yeah, I think also the big thing is that I think we can provide like education, but like we can't provide direct intervention to them because we don't have like the license.
Right,
But we
right.
can
Just like-
provide those education.
Yeah,
things.
showing them what we're doing and maybe they can try to carry over some of it. I don't know, Sally or anyone, if we missed anything.
So I would just say that the only thing that like maybe an MRI would help with is if you were concerned that it was potentially a progressive condition, but that should also show up in their presentation when they're losing skills. And yes, in terms of, it sounds like it would be really nice for like Kelly and Kim to have an offline conversation with Andrea about this specific need. I have actually personally seen folks who came from Guatemala who'd never been to school. They had never seen a doctor or a therapist and actually migrated to the United States. Unfortunately, by 16 years of age, this child had pretty significant contractures. And at that point, surgery was really the best option, but it wasn't going to have the best outcome that it would have. So that the key really is exactly what Kim and Kelly have said, is that any suspicion of CP, they should be receiving services. And it is possible to train local folks to do things, but to give specific recommendations will be really hard for an individual kiddo without a therapist evaluating them, unfortunately.
We're just looking in the chat here. Yeah.
So with Raisha's comment about the tiptoeing, that's a really good question. So we have a lot of kids who come in for OTPT who do toe walk. We call it, when there isn't a neurologic cause to it, it's called idiopathic toe walking. It's where they are walking on their toes consistently, not because of a neurologic cause. We typically want to look into more of a conservative intervention through physical therapy, through bracing and exercises to kind of help stretch out that muscle and improve that gait pattern. But we actually have to really screen kiddos who come in for toe walking because it can actually be cerebral palsy and not an idiopathic nature. So I would suggest if there was a lot of tightness in the calf, they can do some of those muscle tendon reattachment or tendon lengthening. But with kids who do not have cerebral palsy and are walking on their toes from an idiopathic level, we typically try conservative treatment first. I hope that answers your question. So that's a really great question, Leanne. There are some genetic conditions that are actually considered cerebral palsy. I don't know the exact list, but it has been termed that it can be hereditary in some instances, and some genetic syndromes are included under that umbrella of the CP diagnosis. Not all, such as something like Down syndrome is a genetic condition, but is not considered cerebral palsy in most instances. So some genetic conditions are considered CP, and then some genetic conditions are not considered under that CP umbrella and maintain just that name.
I've been expecting you too. Maria, I don't know if we also highlighted your question with answering Andrea's. I feel like CP does require a lot of external medical interventions and care. And I think the best thing we can do right now is just truly educating on the earlier we identify, the earlier we can get them into those treatments so those medical interventions won't be needed down the line or as severe. So I feel like to get those, maybe, I don't know, just getting the word out and education to those areas is something we can try to work on as healthcare providers.
I completely agree.
And kind of highlight that. Great, so we are gonna move on to our equipment portion of this. So feel free to stretch, bathroom, whatever you need to do while we get set up. And yeah. Yeah. Becoming such a Zoom dual screen expert.
Great job, guys. You guys are doing great.
Thanks, Shannon.
Thank you.
All right, share. Sound. This one, yes. Yeah.
And then here. Perfect. All right, can you guys see our screen okay?
Yeah, I think they're good. Okay, great. So we're heading into equipment. I am still Kelly, and this is still Kim. I really want to highlight that this specific lecture on equipment is not specific to just children with CP. It is equipment across the board and something we see in OT-PT. And after the lecture, we really want you guys to be able to define durable medical equipment. We'll refer to it as DME, just the process, and then being familiar with a wide variety of equipment that we're using in our sessions.
So first, we're going to be discussing how this durable medical equipment is obtained through the OT-PT. Excuse me. So durable medical equipment is something that should withstand repeated use, to be used for medical purpose, and should be able to be used in the home. This type of device should be useful for a person who has a medical condition, and it should not be something that is appropriate for someone who has absence of an illness or injury. So at first, it really just general takes a long time. It can take months. And so we often want to start this process early when we think that something is needed. The team often includes a PT and/or an OT, an assisted technology provider, which is actually just a certificate, like someone has a strength and conditioning certificate. This can be an OT or PT, or it can be something called the vendor, who actually is the person who brings the durable medical equipment. So we first then go through the evaluation. We really discuss what are the child's needs and current functional level. We want to look into the child's posture and current motor function, see what types of DME really best fits both the individual and the family's needs. Following that, we do go through some paperwork, including a letter of medical necessity. This is where I, as the physical therapist, or Kelly as the occupational therapist, will write up why this really is needed by the family and how it improves their function overall. The insurance then reviews this paperwork. It can take up to 3 months, and it can be approved or denied if this equipment will be paid by insurance. We are able to appeal it if it is denied. And if there are 2 appeals to a piece of equipment, we actually have a state hearing. And Kelly will be going into a little more detail on something that can help us in this case.
Yes, so also if we are running into issues with getting it approved, we can use a backup of May We Help. I also like to think of May We Help if we have unique situations where we really need creative volunteers of engineers, industrial designers, inventors, welders, woodworkers, seamstresses, doctors, OT, PT, who all come together in this amazing organization to help design and build and deliver custom devices at no cost to hundreds of clients every single year. It's just a great tool to have if we're having difficulty with equipment, or we just have those really unique situations and we need some unique creative minds to come together.
So PTs and OTs often act as a point person in this process, especially since we see them so frequently. But I do want to highlight that there are some other contributors to the process, including, most importantly, the family and patient. The family and patient should be as much as part of this interdisciplinary team with deciding what equipment best fits as the other providers. Their goals and wants and needs should always be considered and be at the forefront of our decision making. But going more into detail, the social worker is often involved in assisting in coordinating care, accessing resources for paying for the durable medical equipment, providing education on government services and payments to individuals with disabilities. We can also use our financial service representatives here at Cincinnati Children's to help us understand and provide somebody for patients to ask questions to about their health insurance. And we also have the DME provider. That is a person who often delivers and provides the equipment itself. Often we will work with the PT in assessing if the device fits and if the device actually meets their child's needs. We can have these DME providers bring the equipment to our appointments at OTPT, or the child can go to the office themselves. We also require the referring physician because they are sometimes involved in the evaluation, but most importantly, often writes the script for the device. So we also are involved in some minor equipment repairs that can be completed within our treatments. We also have to consider how we can grow the equipment. So as the child or individual gets older, we need to be able to make the child bigger and allow for more room for growth. So we can assist with that. We also act as a point person to consider when we need new equipment and when we need to restart that process. So a thing to consider when looking into using durable medical equipment over the lifetime is that insurance wants these things to last a very long time. That with, for instance, with wheeled mobility, insurance will typically pay for a new piece of equipment around every 5 years. But this can vary really based on the individual's health insurance or if they have a change in medical status. But we really have to keep in mind that these are pediatric patients that will grow. So the equipment needs to be able to accommodate for growth and still be easy for the patient and caregivers to use as the child gets bigger. Because it can also take so long to get equipment, we have to really make sure that this is started earlier rather than later. And we have to consider that when we're thinking of what would be most appropriate for a 5-year-old child, we have to make sure that it would also be appropriate for them when they are 10 as well. So it takes a lot of thought and a lot of consideration and a lot of communication with the team and the family themselves to make sure we are getting the most optimal option for them. So we just really have to keep that next year's appropriate in our mind to make sure we have the most appropriate options. So first, we're going to be going through some different examples of wheeled mobility. So wheeled mobility is a type of mobility that is often described as a wheelchair. You are able to have what we call a rigid frame or a folding frame. So the big difference for this is that the rigid one is able to endure more force. It is actually more sturdy and it does better with sports and activity. It's also fairly lighter than the folding wheelchair. But the folding wheelchair usually is better to be used for transporting things in cars. So it can actually fold down for individuals who do not have cars that are wheelchair accessible. Then we can also add something called a power assist on wheeled mobility for manual wheelchairs. So those manual wheelchairs really do require some arm strength, endurance, and postural control in order for the individual to independently move it. So something called power assist can really provide a wonderful opportunity for these individuals that they can use when they get tired to help power their chair and use it from an electricity standpoint. So there's a couple different options. The first one being the M15 power assist. Then we have the smart drive. And we also have a joystick operator. So with these, they can turn them on when they need them, and it turns the chair into a power wheelchair. Usually we find that the joystick option is easiest for the child because it's kind of similar to a console, whereas these types of power assist, they more so have to kind of tap a wheel and it's not as intuitive for the child. Next, we have something called wheeled power, full power mobility. So these types of wheelchairs are typically best fit for individuals who have lower strength and endurance, and they need more assistance throughout the time in being able to navigate their environment. I will say that both the power mobility and the power assist that was on the previous slide does require some safety and cognition with being able to navigate their environment. But one thing that's really wonderful about these power wheelchairs is that they have extra functions, including this sit to stand function, which I will be discussing some of the benefits on a following slide of getting a individual into that standing position who doesn't typically walk. And there's also things such as tilt in space, where the entire chair tilts at an angle, which can provide some pressure relief, such as for an individuals who have had a spinal cord injury, providing that pressure relief so they don't have pressure sores. And there's also a recline function on some of these power wheelchairs, which allows them to rest and can assist with bowel and bladder management. Oh yeah.
So going back to that, also just thinking these have hand functions, they're using a joystick. There are other power chairs that are controlled by a sip and puff if they don't have hand function, or there's one where it's the head control and they can tilt to turn. So there are other options if they don't have hand function as well.
Yes, that is so important. And it's so amazing, honestly, what our biomechanical engineers are able to do with those types of assist. So we also have something called an adaptive stroller. So this is another form of that wheeled mobility. Some of the advantages are that it is compact, it's easy to use, it's easy to transport, it's relatively low cost, and it doesn't have as much of a medical appearance, which some families approve of. But the disadvantages is that it is fully dependent for the child. The child is not able to push themselves or control it via an electric power source compared to the other forms of mobility. There's also limited potential for growth and positioning. It's really best suited for level surfaces, and it can also make the older child look slightly babyish.
Yeah, so kind of thinking like why a caregiver might go for an adaptive stroller. It's definitely huge for safety, and some of our kiddos that might have a history of elopement or running away. This adaptive stroller allows to keep the patient safe and the caregiver kind of having a good state of mind when they're maybe going out into the community or going to appointments. It just keeps them safe and keeps the family secure as well.
So next we will be going over different types of walking mobility aids. So the first one being gait trainers. So these are used with individuals who need some extra support to achieve walking, and it allows them to independently walk for shorter distances in the home. Usually we do not see these out in the community as much because they're a little bit hard to get in and out of a car. But the one on the left is called a Riften Pacer, and the one on the right is actually a Kid Walk. So this next video is actually going to be a video of someone using a gait trainer. He has cerebral palsy. One thing that's really cool about these devices is that there's a lot of different supports that can be added or taken away based on what core and arm control the child has. We'll be only watching the first 2 minutes of this video.
The Riften Dynamic Pacer allows for customized positioning for each individual to improve positioning for better success with gait. There are many ways the frame and accessories can be adjusted during the initial trial and fitting. Set aside time to determine the best settings to improve positioning for better success with gait. Scott is 18 years old with mild cerebral palsy and autism. He has generalized hypermobility and low tone and uses orthotics to stabilize his ankles. In his first trial in the Dynamic Pacer, Scott walked in extreme forward-leaning posture with poor control. We set the brakes in order to adjust the accessories to improve his positioning. We removed the arm platforms and the posts so the clamp could be positioned farther back along the top frame. The dial under the arm platform was swiveled so that most of the surface would be as posterior as possible. The post is now placed to point inward. Each arm platform is positioned so it angles upward. For the pelvic support, we moved the clamp of the handhold farther forward. The handhold itself is placed to point inward so the pelvic support straps are closer to Scott's hips. With the straps tightened, the pelvic support will now provide better control. We engaged the swivel lock on the rear casters and set the drag with increased resistance to help Scott gain better control of the frame while walking. With these adjustments, Scott walks in a more upright position and with far better control.
So that's a great example of what we can do with our gait trainers in physical therapy. Our next mobility aid is actually considered a walker, a pediatric walker. These are actually less supportive than a gait trainer overall, and they're better to be used in the community and longer distances, since it's easier to move in general from the child's or individual's standpoint, and also easier to transport. We typically have posterior walkers or anterior walkers. So that means depending on if their hands are in front of them or behind them, or where the walker is placed. We prefer this position. This is called a posterior walker because these children usually have a little bit more upright position in this case. Then we can also use something called crutches and canes. These are loft-string crutches on the side, and on this side there is a tripod cane. So these have even decreased support compared to the walker and gait trainer. So individuals who utilize these need to have more balance and improve coordination in order to safely use them. I sometimes see individuals who've been diagnosed with spina bifida use loft-string crutches, or individuals with cerebral palsy who have a lower GMFCS level. Finally, I would like to talk about something called standers. So these are really helpful for individuals who are not walking by themselves in order to get into that upright position. There's been a lot of research found that actually being in a stander for 60 minutes a day can improve what we call lower extremity passive range of motion, which is that acronym on the first bullet. We have also found that this is really beneficial for overall respiration and physiologic function. So it allows them to place weight through their legs and improve bone density. It allows the heart to pump against gravity, which improves heart function and endurance. And overall, I've also just seen that this is really wonderful from a participation standpoint. Instead of them just sitting down, they can do standing activities with their family and friends as well.
All right, so now we're going to kind of look at seating. So we have a various type of supports for sitting to, again, like Kim said, increase participation, whether they're in home, therapy, or the school setting. So the first one we have here is called the Rifton Activity Chair, which is used, again, in OT treatments, feeding, whether they're at home or school. But I will say this one, unfortunately, is hard to get covered by insurance. So it is something we try to get for families, but is not always guaranteed. And the middle one here, we have the tumble form, which is great for those younger kiddos who maybe don't have great trunk support or have trouble sitting. So we can kind of put them in that upright position, whether we're engaging in feeding or just want to work on maybe visual tracking and having them just sit up and be in a new part of the world that they might not have been in before. And the last one here is the Rifton Toddler Chair, which I feel like is like the OG compared to the Rifton Activity Chair. It is great. You can find one on any of our OTPT floors. And I would just try to imagine a tray there, because we typically put our kiddos in and we put the tray on. And whether, again, we're working on feeding or just want to have them play with the piggy bank, it's just great to really engage them in those activities and put them in positioning in that upright position. So now kind of looking at transfer equipment. So the first one here on the bed, which you see the wheelchair with the board and then the bed. So this is called a sliding board. And I've had a lot of experience with this with spinal cord, but it's typically used for paraplegia, so CP, or wheelchair dependent. But it also could be used for patients that may just be non-weight bearing or have percussions or weakness. And it's a nice cheap little tool that you can have, and you just slide it under their bottom. And you're gonna either provide support at their trunk and kind of carry them along, or depending on how much upper extremity strength they have, they can scoot themselves along the board. And it just kind of gives them that little, I don't know how I want to say it, the little safety net between the wheelchair and the bed, or wherever we're transferring them from. And then in the middle here, we have a Hoyer lift. And all I can say with this is safety, safety, safety. So when we are putting the sling under them, we might roll them back and forth to get the sling. And then we're going to carry the little cart thing and have it come down, attach the sling. And why I say safety is when we put them up in the air, there's very limited things that we can do medically if something were to happen, if their body goes into shock or their blood pressure or oxygen. So we're always checking for lines and making sure we're clear before we transfer and getting them, whether we're transferring to mobile chair, etc. And then another thing that is a great option, but is not always realistic, is sometimes families will install these lift systems into their home. Insurance typically does not pay for this, so it's usually out of pocket. And I will say, you need a large home. This is a huge piece of equipment, and Medicaid waivers may pay for them for kids in Ohio, but few kids in Ohio qualify for the waiver program. So Hoyers aren't always the best option at home. So we work on different transfers like the sliding board and other things based on the caregiver's needs. So then moving into school and handwriting, we have quite a few here. That first one is going to be called a slant board. And you can see it's the blue thing on the desk that's kind of allowing the paper to be held a little bit closer to the child's face. It really helps them maintain that 90-90 posture. And it's placing their wrist and hand in a good position for that functional grasp. So you can see the wrist is an extension. I also like this because they're not moving their whole arm and they're really having to use their wrist for movement. As well as when it's slanted, it's going to decrease that pressure. Some of our kiddos really don't have that body or proprioception awareness, and they're like fisted, scribbling on the paper with so much force. So that just kind of helps bring awareness and decrease the pressure used when writing. It makes visual tracking a little bit easier, again, that it's closer to their face. It's going to hold the paper in place. And there's a little less neck movement if they're copying information from the board. They don't have to go all the way down and up. And the middle top there is a little pencil grip. I'm sure we've all used the fun ones in school when we were younger. This one's great because it's really, again, helping them maintain that mature grasp for writing. These allow to kind of reduce fatigue and pain. And it's love to use these for our hypermobile kids. So those kids that might be like, hey, watch what I can do. And they fling their elbow into hyperextension and you're like, oh my gosh, please don't do that. They also tend to be like hunched over and have poor core strength. So they also might use the slant board as well. But again, it's all about helping them get in that good position to decrease pain and endurance. The far right, I guess, yeah, far right is going to be adaptive paper. So this one noted here is highlighted paper. And I love this because it really, even for in general, it helps kids learn top and bottom and when they're writing their letters. We also have raised line paper, which helps kids give a tactile cue. So just kind of thinking of how creative we can be when helping them at school. The bottom left is going to be called a wiggle seat. And these are those kids that you might see that are a little squirmy and they just can't seem to sit still and they might need that extra movement. And it just provides that sensory input to allow them to be successful. And here's another picture of the written activity that I highlighted previously, but you can see a child sitting in it and has a tray there to engage in a school or home setting. So moving on to sensory equipment, I always like to highlight because I feel like a lot of times in OTPT, it may look like we're just playing with the kids, which we really are. And that's why I love my job. But we're also looking at so many other things when this is occurring, especially when using sensory equipment. So always like, if you see a kid on a swing or something, we're typically pairing it with an activity during it or providing sensory input and then completing a task. So in the middle, you see the kid coming out of what we call a steamroller. And if you've ever been through one of these, it provides a ton of deep pressure for you and it's super tight. And some of our kiddos just really need that to help kind of regulate, and the deep pressure can be calming. So sometimes with this, I might have a kid go through and then put a puzzle piece down and then we continue the obstacle or cycle. We also have a kid here, which he looks like he's in a comfy, what we call a body sock. And again, it's providing that deep pressure, but this also kind of brings in proprioception awareness. Again, can be calming and organizing for the kiddo. The wiggle seat I mentioned before in school setting. And then at the top right, we have a weighted blanket with a big X around it. There are no weighted blankets at Cincinnati Children's. It is a safety hazard. However, I do think it can provide some great safety and calming input to children at home. I always just really highlight to caregivers that we want to make sure that the kid isn't left alone. They might not have the core strength or fine motor dexterity to pull it off of them if something were to happen. So not sleeping with it or things like that. But we do notice kids with anxiety, ADHD, or autism, it can improve sleep or for calming situations. I also really like fitted sheets for some of my kiddos. I've seen good success with those. And then the bottom right, we have a swing. This is considered a platform swing. So kind of looking at this, it takes a lot of trunk control, a lot of cognition. I always tell them they have to hold on, they have to be safe. There are a lot of rules before just putting a kid on a swing. But I love the platform swing because it's offering those tilting movements. So you're working on their balance, you're working on core strength, and also bringing that body awareness and postural adjustments. So sometimes I'll have a kid sitting on the corner and they're like, why won't this go? And I'm like, I'll put a mirror in front of them. I'm like, why don't you like figure, like kind of have them problem solve and figure it out of like, oh, if I move my body to the middle, I can swing. And it takes some time to get there. But I love, again, really having the kid problem solve and think about it. And then also putting them on a swing can provide sensory processing or sensory input to them. I like to go in that linear motion because linear is shown to be calming, while that rotary can be super alerting. And I never want to put a kid on and have them just start whirling around because I never know what I'm going to get at the end of it. So just being mindful of when we're putting them on a swing, why we're doing it. So then moving into feeding and oral motor skills. So there are so many things that we can do to help our kiddos and individuals be successful while eating or starting to learn how to chew. So the first one on the left with the angled spoons, really good for that limited range of motion. Sometimes our CP kiddos might use it. It's going to be closer to their mouth. We also use built-up utensils, so maybe they have decreased grip strength. Again, limited range of motion. That weighted utensil and the larger is allowing them to hold on with stabilization. Then we have a bowl here, and you can see under it is that blue little patch right there, and that's called Dyson. And if you've ever felt Dyson, it's pretty sticky. So I can put the Dyson down and then the bowl, and that's going to help the bowl stay there. So maybe if they don't have the most accuracy when going into the bowl, but they can scoop, that just allows them to be successful without the bowl spilling over. And then this little blue bowl down at the bottom right is kind of a scooper bowl. So it's nice because it has a higher edge. So then when they go into scoop, they can really use the whole side of that bowl to get yogurt or oatmeal or whatever we're working on to eat. So again, just helps with that decreased range of motion in the wrist, to help with scooping. Nosy cups, I think we talked about nosy cups recently. Yeah, to kind of, they're awesome. On Tuesday, yeah, that's right. So they're great for kind of that decreased range of motion with the neck and being able to tilt when also using a cup. And then some sensory oral motor skills that we have here on the bottom left is a Nook brush, and then at the bottom is a Z-Vibe. I love these for kind of that preparatory work of getting those kids warmed up and kind of bringing awareness to their cheeks and their mouth and their teeth. And like the Z-Vibe's great. It's like an electric toothbrush is what I can equivalent to. So some of those sensory kids that might not want that input, it kind of like works it up to like, well, like we'll just play with it and then we'll tap our cheeks and we'll give it a kiss and just kind of bringing that awareness to their mouth. Same thing with a Nook brush. We might roll it on their tongue to work on lateralization of bringing our tongue to our teeth and kind of, again, having them, it's almost like reps for your mouth. It's like you're doing a bicep curl, we might do some rolls of the tongue to strengthen our mouth muscles. And moving on to bathing. So there are quite a few different equipments we can use in the bathroom. And I think when we look at this type of equipment, we really want to think, how big is their bathroom? Do they have a shower? Do they have a walk-in shower or a tub? Also, how large is the kid? What is the need of the caregiver? So really taking all of that into consideration. So the top right, one of the more simple equipment is a long-handed sponge. And this just can help kids increase independence by reaching different parts of their body and washing if they have limited range of motion. Right here in the middle, right here in the middle is called a tub bench. So this is going to allow, if we need to transfer into the tub, we'll bring the wheelchair angled and either using a transfer piece of equipment or lift and put them onto the bench. I do love the tub bench because it is pretty stable, but when considering it outside of a tub, a lot of families have to cut that shower curtain because water is going to spill out. So always, again, thinking about safety when transferring. It's easy to get them in, it's not wet, but when coming out, so just being mindful of that as well. And then the shower chair, which is the bottom left right here, that fits all the way into the shower, so it's smaller than a tub bench, and it's designed to fit into any shower. It also allows more room for the caregiver to stand outside and help wash if they need to, so that's a pro for that one. And then on the far left, we have the shower buddy or the tub buddy. This is great because it really has so many components, and you can see it can slide in and also go over a toilet if they want to use the bathroom. It's really beneficial to our older patients that might be a little heavy or not safe to transfer and need some more postural support. You can clip in using the chest strap. And again, it can roll in and out. So that's just a great thing. It's not going to stay in the bathroom. And then lastly, we have the wave bathing, which is also a Riften chair. I know we talked about the Riften activity chairs. This is something used in the bathroom. I love it because it's for our smaller kiddos. Again, it has head blocks, it has a chest strap. It's used for the bathing, so it can be used in the tub or shower. And it's, I think, great if you have the handheld removable shower, the caregiver is able to just watch the child sitting there. So pros and cons to all of them and a wide variety for the families. And then moving on to toileting, there are quite a few. On the very left here, we have a raised toilet seat. So this is kind of providing safety and ease for when you're getting up and down the toilet. One thing with this, I just always want to make sure it's properly installed. The raised toilet seat is designed to decrease falls, but always just, again, being mindful of when we're putting this equipment on and making sure it's safe. In the middle, we have a Riften toilet chair. And this, again, is just huge for positioning. It just allows the child to be upright and tilted and just give that ideal natural effect for toileting, which I think is huge for our kids. We want to give them as much independence, and toileting is something that can be private. So the more we can help them be successful is huge for us. And I also love this specific toilet chair because it's used on and over or off the toilet. So you have a lot of variety when using it. And then going back to independence on the far right, it's just a wiping aid to help increase independence if you have that limited range of motion or accuracy or weakness. Wiping is probably one of the hardest things I think to teach in OT, but just giving them those tools is always a great option. I think this is my last one. So dressing, again, I feel like people have just gotten so creative with adaptive equipment to use with our patients and so many options. The first one on the left is a button hook and allowing them to kind of hook on the button and slide it through. Great for decreased fine motor skills or if there's one side that's affected of their body. There's also magnetic buttons up, so you have that option as well. For dressing, this is called a sock aid, great for those who have hip or spinal precautions or just limited range of motion bending down. Put the sock on, swing it over, and it slides right on. It's actually pretty cool how easily it works. And then shoelaces, there's elastic shoelaces, or sometimes I just recommend, if possible, you don't have to buy, I feel like there's so many different kinds of shoes. You can just buy slip-on shoes. There's so many options. And then the bottom here, we have Billy shoes. A lot of our kiddos wear these that have orthotics that Kim mentioned before. It's great because you can see this, there's the orthotic, and it looks like it's tying, and then it just zips around right there. So it's just a great option. You slide them in and zip it up, and they're really fashionable shoes. So super fun for our kids. I think that, oh, of course, how could I forget? Adaptive sports and recreation. So there are just so many options outside of just equipment, and we're looking at activities of daily living. And as we highlighted, we want our kids to get out in the community and be participants. And what we really try to highlight is there's no limit with these kids. They can do anything that they put their minds to, and it's not what they can do. It's just what they cannot do yet. So they want to do that. We'll figure out how to help them get there. And adaptive sports and recreation is a great way to highlight that. We see tennis, bowling, skiing, water skiing. So just really helping them get to where they need to be.
Yeah, I absolutely love adaptive sports. It's one of my big passions within physical therapy. And I also like to highlight that technology is constantly improving in this area, and adaptive equipment can really just help us improve participation in these adaptive sports. They're creating new wheelchairs, they're creating new supports all the time. And we just have so much more potential to improve in this area.
And now we want to give a huge thanks to our LEND faculty and our supervisors for helping us get this presentation together and building our confidence to be able to give this information. It's so valuable to teach our team, our OTP team mentor specifically, as well as our LEND trainees for your time. We hope it was helpful. So, any questions?
And that can ick me on the CP presentation or the equipment presentation. We're all yours.
I like that Maria pointed out, Perfect North has a tandem skiing and a bobsled looking cart for two ski instructors.
Oh,
That's
fantastic.
Awesome. And thank you guys for all the kind comments. You guys are so sweet. Well, and we ended early, so now you guys get a break now.
And Callie has just been so much fun to work with. She labeled us the dynamic duo earlier in our emails, and we've had a lot of fun working together on this. So we appreciate your guys' time and listening, and letting us explore all of this and share our expertise.
I have a real quick question.
Oh, Pat, you're kind of quiet. Can you speak a little louder?
Yeah, I have a real quick question. Can you hear that? Okay.
Yes. Now
I was looking, it kind of goes back to the first part of your presentation. I was looking at the number of teams that are used to work with this. And since this does not get progressive, but it is long-term, and the approach was more comprehensive, the question I have to ask is there a reason why psychology or psychiatry and chaplaincy are not a part of the group? Since this might, I'm always thinking holistically, and we always think of mental health after there's an issue, but since this is long-term, there has to be some implications, if not for the child, for the family. And so I was just interested, as I was scanning all of the teams, I didn't see psychiatry or psychology and spirituality or chaplaincy as well. So I was just wondering if there was a reason why they aren't included.
I think that is a fabulous question, Pat. It's something I feel like I didn't even consider until really working on this presentation. I think they play a huge role in behind the scenes, and that we maybe should consider including them into these clinics and as a resource. I know we have social work and one or a few of them that maybe could connect them, but kind of bringing them to the forefront, because it's a huge thing. And you're right, we do consider it more after when they're older, but we really need to hit it harder when they're younger.
Yeah,
absolutely. Before it starts.
I will say that a lot of the kids who are seen in cerebral palsy clinic, it's a very comprehensive assessment that they're given, and the children are often referred to psychology for if there's behavioral issues. They're all referred for neuropsychiatric testing if they have cerebral palsy before they enter school, so they get a comprehensive evaluation about how they'll best learn. And we really encourage, and we have like a CP Facebook page, really parents networking, because that's a really important part of that support piece as well. But certainly there are ongoing referrals with psychology for children with cerebral palsy.
Yes, and that I understand that, but what I'm saying is, as the teams are meeting from a comprehensive perspective, and everybody's giving consistent input, wouldn't it be better to have them in there as a part of the team meetings, and then giving input if they see something, or or even they can bring something up that the rest of the team may not even think about doing. I get the part about the referral. I'm just talking the part about bringing them into the team. And so that they're there whenever the team is meeting and conducting a team focused presentation on that particular child. That's all. I was just bringing that up. I get the referral piece, but the referral piece often to me is they're out of sync with what the rest of the team is doing. But if they're in there when the team is meeting, then they can give the input, or even another team member could then give a suggestion to one or both of them. That's all. I was just bringing that up.
No, I love that idea. I think that's great.
Me too.
I appreciate you saying that, Pat, because I think that even my short time in the civilian side so far compared to the military, I don't see as much religious input as I have in the military. And so we still have chaplain involvement, but still not to the extent of what you're even asking and inquiring to. But I think that chaplains have become more integrated into our regular practice in the military settings, just because of how some of our training opportunities have been with active duty and then incorporating in family care compared to civilian side.
Yeah, I think that we definitely as a healthcare system as a whole need to just continue growing and like including mental health and including religious beliefs. Like I know that in cerebral palsy, there can also be a lot of anxiety, both in the family and in the individual who has CP. So it's really important. I love that feedback, Pat. Always appreciate your thoughts. And it's really helpful. And same for you, Nicoletta, as well.
And I like that Risha put in Grace as a safety stroller, and psychology was the one that informed them about it. So just going to show how important our psychologist friends are. All right. If no one has any other questions, we will pass it off to Jen and we can head to SCBM.
Yeah, does anybody need anything? Okay, well, have a good rest of your day and we'll see you next week.